AETCM, the Emergency Medicine Channel. Today we are presenting a case of 26-year-old male who is a known case of bronchial asthma. He was having history of upper respiratory symptoms like coryza since 2 days, and he was on MDA aspirin SOS. So he is a smoker also. So he was having breathing difficulty. As per his friends, he was having breathing difficulty and aggravated since afternoon on the day of presentation, and he was arrived into the ER. He was very much in respiratory distress and agitated. So initial 10-second assessment, airway was patent. There was no. He was able to talk, but was not able to complete one full sentence. And breathing bilaterally, air entry was reduced with a saturation of 67% on room air, and respiratory rate was around 35-40. And coming to circulation, BP was 150/100 millimeters of mercury with a pulse rate of 102. And all peripheral pulsations were equally felt, but peripheral cyanosis was there, like fingertips.
Peripheral?
Mild cyanosis was there on fingertips. No central cyanosis. Coming to disability, he was too much agitated, and we were not able to. We initially started on NRVM and started on nebulization, but he was so much agitated that he was pulling away the mask. And after some time, that he was. We were trying for nebulizations and oxygen supplementation, but the patient suddenly had a episode of unconsciousness with unresponsiveness with frothing from mouth, and at that time central pulse was not found. So we had started on high quality CPR according to the ACLS protocol and intubated immediately, suspecting hypoxic cardiac arrest. And injection adrenaline 1 mg IV was given. First one dose was given, and dose was achieved after intubation. So the ABG was taken after intubation during the cardiac arrest. It was showing a type 2 respiratory failure. That is, the pH was 7.2 with a PCO2 of 70 with a bicarbonate of 20. So acute respiratory type 2 respiratory failure.
Acidosis.
Respiratory acidosis. And he was so initially, once after 6 minutes of CPR, ROS was achieved, but his tidal volume was not achieving. That time also we were having air entry was very much less bilateral. So we had started on adrenaline infusion and aminophylline infusion and ketamine infusion, but he was again went into cardiac arrest, and again ROS was achieved after 2 minutes of CPR. And he was started on aminophylline, ketamine, and adrenaline infusion, suspecting hypoxic cardiac arrest. So he was admitted in a ICU, and he was not at all sedating, even with 3 sedatives. We were started on ketamine infusion, midas morphine infusion, and also dexmedetomidine infusion. But with 3 infusions, patient was not at all sedating. So we had sent for.
In that situation, what are things you suspect when you are not able to sedate somebody?
Either patient will be alcoholic.
Okay. One is alcohol, takes large amount of alcohol, drugs may not act or they may not give a good effect. Okay.
Or else he will be using any recreational drugs.
Recreational drugs or morphine or diazepam-like drugs. Okay. Anything, drugs, those are taking drugs, the requirement for sedatives will be much higher than a normal person. That we have to keep it in mind. Any patient we are unable to make him sedate means he may be under the influence of some other drugs, or he is chronically taking some other recreational drugs, including alcohol.
So he was initially had started for his infective markers were mildly elevated with procal negative. So we had started on ceftriaxone.
Infective markers mildly
elevated. CRP was
CRP is not an infective marker; it's an inflammatory marker.
CRP was around 15 with a WBC count of 8,000 with procal negative. So we had started on azithromycin, fluvier, and ceftriaxone, and was on multiple sedatives. So since he was not sedating with these 3 drugs, we suspect any other brain stimulants he was taking, and we had sent for toxicology samples for urine.
So you think any drug stimulant is on or is in the withdrawal state?
Withdrawal.
So it is withdrawal. If somebody is on stimulants, he should not develop asthma. Because whatever we are giving for asthma, it is same, all same. Alpha stimulants, beta stimulants. But if the patient is having a respiratory problem and now you are unable to make the oxygenation properly and you are intubating.
So the urine was showing MDMA. The toxicology samples were sent, urine was showing the presence of MDMA.
Okay.
And
MDMA is stimulant or suppressant? Stimulant.
and then after
What are the suppressants patients usually take?
opioids.
Opioids.
Alcohol.
Alcohol is not a suppressant. Initially it is a stimulant and at one point it will become a suppressant. Amphetamines, the other things are stimulants. Suppressants. Benzodiazepines. Benzodiazepines are commonly used nowadays for as a suppressant and even toddy they use it, toddy, to give kick. So that is a suppressant. So which one will produce asthmatic episode? Stimulants or suppressants? Stimulants will not produce acute asthma. On the withdrawal it can produce. Okay. Whereas suppressants can have asthmatic episodes or they can have respiratory depression, all these things. Okay. But various levels of the stimulants, some level it can also produce asthmatic episodes.
So after 2 to 3 days, his sensorium was gradually improving, and he was obeying commands. And he had fever spikes after 2 days of admitting in our ICU.
So what you suspect when you have a patient who was intubated and he is developing fever after 48 hours? What else you suspect?
Ventilator.
So we should always suspect a ventilator associated infection growing up.
So we had added vancomycin also, and minivan was sent.
Okay, why vancomycin?
Coverage, pseudomonas.
Pseudomonas. Vancomycin.
Hospital.
MRS. Pseudomonas is different. Pseudomonas you use some gram-negative coverage like piperacillin as well. Vancomycin is added to cover MRS. That is one of the common hospital-acquired or ventilator-acquired lung infection.
And then minivan was sent, but there were no organism or inflammatory cells. And then he was extubated to CPAP by ketamine infusion, and then ketamine was.
What is the advantage of ketamine infusion?
There will be no respiratory depression. And then he was having some mild dysphonia. The sound was not there, but we had started on oral feeds and advised flexible endoscope if symptoms were persistent, but it was gradually improved. And then we had given a psychiatric consultation for de-addiction also, but he was not willing for further psychiatric management from there. So we discharged from our side. So we had a near-fatal asthma. So
Silences.
silences.
So what is silences?
There will be no energy due to severe
So
public
when you oscillate, you don't listen any wheeze. So sometimes you'll miss the wheeze and you will think that patient is alright. The patient is severely symptomatic because of the hypoxemia, acute type 2 respiratory failure, acidosis.
So the risk factors for death from asthma is past history of severe exacerbation, more than or equal to 2 hospitalization for asthma in the past year, more than 3 emergency room visits for asthma in the past year, more than 2 canisters per month of inhaled short-acting beta-2 agonist, illicit drug use, psychiatric disease or medical comorbidities. So then we have status asthmaticus. Initially we try with our medicine beta-2 agonist and IV steroids for reduction of inflammation, and IV magnesium sulfate for smooth muscle
How
relaxation.
many cycles you have to give nebulization?
3 cycles.
3 cycles. What are the anticipated side effects of nebulization?
Tachycardia, palpitations, tremors,
Sweating.
hypokalemia.
Okay.
So magnesium sulfate.
Hypokalemia is what type of hypokalemia it is?
Shift.
Okay. Shift type.
Magnesium sulfate can be given. It is also a smooth muscle relaxant so that bronchodilation can be had. Then if not managing with nebulizations, we can try on non-invasive ventilation with CPAP. Then ketamine infusion can be given because it also have a bronchodilatory action without any respiratory, even though it is sedative, without respiratory depression. And adrenaline can also be tried, 0.3 to 0.5 mg.
What about morphine?
Morphine will decrease the anxiety so that
Say, very small dose of morphine, 1 or 2 milligram, will be beneficial for most of the patients. Very high dose of morphine, you might have learned that it can produce respiratory depression. In small dose will relieve the symptoms in most of the patients, including COPD and asthma. Even in pulmonary edema also, we can.
if nothing is happening, we can even try ketamine nebulization.
Okay.
And in near fatal asthma,
Adrenal nebulization.
adrenaline nebulization can be given, but more mainly for upper respiratory.
Okay, it is same like you are giving adrenal subcutaneous in what is it, anaphylaxis. May act like that because when you are giving nebulization, it go to the respiratory tract and from there it will get absorbed. So we can try it, but it may not give effect like what you are giving in subcutaneous.
Then mechanical ventilation, that is like we can prevent the hypoxic arrest, and also with tachypnea, patient can go into respiratory muscle paralysis. So to prevent
Do you
that,
want
for
to take
example,
an X-ray in asthmatic patients?
X-ray, we can to rule out any pneumothorax.
That is very good. Pneumothorax should be ruled out in severe asthma patients.
Then any pneumonia can be also found out.
Okay.
Then aminophylline can be started.
What is the indication for aminophylline and what are the side effects of aminophylline? Is it current guidelines advise aminophylline? It is not. It is removed because of the toxicity of the drug, but it is a good drug. How do you give aminophylline?
2 ampules.
2 ampules is 500 mg.
500 milligram in 5 ms over 24 hours.
And dextrose,
Dextrose.
DNS,
Yes.
or 24 hours. Okay. In patients who are on aminophylline, continuously they are on taking aminophylline, that dose may not be sufficient. So in that case, you may have to use slightly higher dose. But the problem is aminophylline can produce arrhythmias. Okay. Especially when people are taking arrhythmias. So we have to be very careful. What are the actions of aminophylline? Where all it can be used? Actions of aminophylline. Bronchodilator. Heart. Heart is a stimulant. Okay. It increases pumping. And diaphragm improves the diaphragmatic contraction. So it's smooth muscle contraction it improves. Okay. So everywhere it will improve the function, including the blood vessels. It produces dilatation and produces preload and afterload reduction. So you can give in most of the breathlessness, aminophylline can be given, but only thing is nowadays we are not using only because of the arrhythmogenic property of this drug. Okay, so it is we are avoiding this, but still in severe uncontrolled asthmatic episodes you can use. Okay, magnesium, potassium, protein.
Magnesium sulfate we can give 2 gram, 1 to 2 grams IV over 20 minutes.
Potassium.
Potassium is required for the respiratory muscles.
Action.
And
Salbutamol.
we increase the potassium, so we have to monitor potassium, low potassium, right, high protein diet.
High protein diet.
This will maintain protein and
Protein loss is carbohydrate. Will you include carbohydrate? We try to avoid. We try to reduce it in patients who are having asthma, COPD. When there is an acute problem, afterwards you can. Anything else?